So then in surviving World War II veterans, we are losing some of our old veterans. And this is again from a few years ago, but here's where we are with the red line. So back when this graphic was created, we still had over 500,000 World War II veterans. Now we have diminishing numbers. This graphic shows that even in 5 years, the total number of World War II service members has reduced by approximately 300,000. Or at least, yeah, 200,000. So I'm going to stop sharing for a moment because I want to be able to show you this video. And I'll tell you a little bit about this video first. And I already sent Tom the link to this video. So because I'm not able to share it with you, I'm going to have you mute your cameras, you know what I mean, mute your microphones, and watch the video after he sends it in the chat. But let me tell you a little story about this. So for those of you who don't know StoryCorps, they were a mobile sort of like a big RV that went around and stopped off in various places in the country, especially in New York City, and had people go into this booth and interview each other. And so so that's the context of this particular video. But while I was in Seattle several years ago visiting some friends, I actually had the opportunity I was up late. It was New Year's Eve, right? And we were up late and just channel surfing at a friend's house, and this video showed up. And I saw it, and then it was gone. And so, but I hunted it down and got permission by the Rauch brothers, who produces these videos, to be able to show it for these presentations. And so, oh, really? So we have actually somebody who actually knows StoryCorps intimately and actually did an interview with StoryCorps. So that's pretty cool. So I'm going to stop right here and have you watch this video, and then let's spend a few minutes just talking about sort of what comes out from watching this video for you. It's 2 minutes and 25 seconds long. Can you guys hear me? Okay. I have this button over here and I can't ever remember like which one's unmute and which one's mute. Anybody want to share and unmute yourselves about your reactions to this gentleman's story?
This is Paul Stayback, King County Veterans.
Okay.
You know, the way he, I think the way he remembered, you know, the enemy soldier that he hit. You know, the way he remembered the way he presented. You know, his physical aspects. Those are things that stick with people, I think, even based on my own experience. And sometimes, yeah, I mean, I think that's what haunts people a lot too. It's those things that we identify with, you know, even though it may be the enemy or something you had to do, because the gentleman presented, it's like, hey, I had to shoot him with what I had to do. And so on one hand, he's absolutely okay with it because it was his job and that's what we do. But then there's the flip side of the things that you do remember, the human aspect of the interaction that sticks with you and haunts you.
Okay. Thank you, Paul, for sharing that.
Hi, this is Adria with the Multi-Service Center. I think in what we still see with clients that we deal with today is the battle of two sides. His battle as a soldier that, of course, like Paul said, he knew what he had to do, but then the battle of his morality. I just shot a child. You know, we don't know if maybe possibly he might have had a child or a brother or sister that same age. And I think that's what the hard part of it is both of those dualities that he had to deal with at that time. You know, I am a soldier, I had to do it. But then that next night, morality kicks in and it's like, I shot and killed the baby. I know that wasn't a full grown man, that was a child. And I think from that point on, it becomes a lot more in depth in the soul of what you have done, not the duty you had to do.
Yep. Thanks, Adria. Others?
Sorry. What stood out for me most was the fact that he described, like, you know, before he even started getting into the emotional speech, he had to describe how this soldier looks like, and I feel like, you know, it affected him a lot just because, like, this person looked like him probably, and he didn't expect that to be the case, and that kind of, like, you know, probably shocked him. It was like, this is a human being that looks just like me, you know.
Great. Thank you. So you notice how he said he was like an angel, right? And so several of you guys, even in the chat, are noticing that that's where his memories of that stayed stuck, right? And so oftentimes, especially with World War II and Korean War veterans, they didn't get the level of intervention because nobody understood PTSD the way we do now, you know, 50, 60 years ago. And so people like Joseph end up being in this situation where they're hoping that time will heal. But when it comes to this kind of meaning making that he had about who this was, and you can hear the conflict, right? Even in this short disclosure where he's saying, well, I had to, right? And he was like an angel. And so the conflict now, just like Adria had noted about the morality, but the conflict was, I shot an angel, right? And so without that ever being disclosed by a trauma survivor, those are the thoughts and connected emotions that live and don't go away, because time does not heal at this point. And they were of the generation that did hope that time healed. So let me go back to my PowerPoint, but thank you for sharing in the chat Am I back to doing it correctly, or am I in reverse order? Yeah, I'm okay, right? I don't have to swap displays. Tom, will you tell me if I have to swap displays? Okay, I'm good. Okay. So what stands out, and as you guys picked up on, which is why I show this, is that there is lifelong trauma, that there is no, there's a lot of natural healing that can happen, because obviously this veteran ended up being able to, you know, move on and do some things. But yes, this is the worst memory of his life. And it stood out for him in a very painful way. I mean, so many years later, he did still live with this horrible pain. And so part of what we need to talk about then is this overall context, because what we don't think about sometimes when we're dealing with older people is, and especially if they have traumatic events, is this whole context of the human developmental cycle. And so part of what I try to encourage people to think about as you're working with clients is, how old is the client now? How old was the client when they were first traumatized? And that might include childhood, obviously. And if there's multiple traumatic events, how old was the client during each one of those traumatic events? And you want to, so what we try to do is match the developmental stage with the issues presented developmentally, as well as within the trauma story, but also thinking about in terms of where they're at now. So it becomes more complicated than just working with the traumatic memories in therapy or counseling or whatever healing modality that you use, and not taking into account where they were in the developmental cycle when they were hurt. So the way I think about it is, I consider PTSD symptoms as related to the actual developmental stage during the traumatic event, and then think about the aging issues now. So when I was working on this grant proposal for the Hartford Foundation, what I found was very enlightening, because I found that there was a paucity of information about aging trauma survivor interventions. It was pretty remarkable to me, because I had been in the PTSD world all this time and for like years, and then said, okay, I'm going to jump into the gerontology literature now. And lo and behold, it was like empty, almost empty. So part of what we think about now, so let's go back to like psychology, high school psychology, or Psych 101, for those of you who took that during your university years. So Erik Erikson discusses the psychosocial stages of development. And here is the entire kind of listing of them, starting from newborns and infants and toddlers, and then maturing into young adulthood, middle adulthood, older adulthood, and then old. But the two I'm going to focus on are in this slide here. So, but I highlight here in yellow part of what can also help practitioners think about in terms of the developmental stages that somebody might be stuck in, and how it provides kind of a framework for understanding how you can broach your interventions with your clients. So if a client was traumatized during the preschool years through incest or witnessing domestic violence or some sort of sexual abuse or physical abuse, then you want to think about how they were traumatized during initiative versus guilt, in which case Erikson talks about that they're supposed to be exploring at these ages, but children who try to exert too much power experience disapproval. They result in a sense of guilt. So then you have this guilt part that sort of lives on throughout someone's lifespan. But then you also want to consider, like, okay, if there was a traumatic event that was experienced between the ages of approximately 12 to 18 years old, this is when they would be in identity versus role confusion, and where social relationships are starting to coalesce for adolescents. So in this regard, you would think about Erickson saying that teens need to develop a sense of self and personal identity. A success leads to an ability to stay true to yourself, while failure leads to role confusion and a weak sense of self. And I could tell you that with the clients that I've worked with at the vet center specifically, I would notice, I could hear some guilt, or I would hear like this sort of like lack of self, lack of grounding in oneself. And if you assess somebody's trauma history across the lifespan, then you can actually pick up on potentially how these sort of exaggerated versions of guilt or exaggerated isolation occurs, or the lack of confidence and self-esteem. But more specifically, with the Vietnam vets that I worked with in my study, I focused on young adulthood, 19 to 40 years old, and maturity. Okay, so Vietnam vets, at the time that they were deployed to Vietnam and went for at least one tour for the most part, maybe 2 tours for some, 3 tours for a rare few, but sometimes they are in the Erickson stages of intimacy versus isolation. This is where relationships are really solidified. And if somebody is a young adult and in a war zone, they are at that relationship stage, intimacy versus isolation, where they need to form intimate, loving relationships with other people. Success at this stage leads to strong relationships, while failure results in loneliness and isolation. If we pull back from that for a moment and think about the major symptoms of post-traumatic stress disorder, social isolation is one of those major symptoms. It's one of the 4 major symptoms listed in the DSM-5. So if you think about it, it kind of makes sense that as somebody is actually in a war zone and they're at that developmental stage where they would actually be making connections, and they do make connections, if some of those connections are tragically lost through a war zone incident, then suddenly somebody's going to be pulling back, because the full manifestation of that relationship was never fully realized, because now they're traumatized as a result of making connection. And so this in lies sort of like, oh, there's some evidence of traumatic stress symptoms also echoing back to this developmental stage. Now, jumping ahead, not that middle adulthood is not significant, but jumping ahead to maturation, ego integrity versus despair, which is the last developmental stage that Erickson discusses. And this is when people reflect on life. So Erickson talks about older adults needing to look back on life and feel a sense of fulfillment. Success at this stage leads to feelings of wisdom, while failure results in regret, bitterness, and despair. So I'm going to talk about this for a few minutes, and then I'm going to harp on it in a few slides too. But just to let you know, here's part of what that really speaks to. As we have aging trauma survivors in our work, in our caseloads, as we end up working with people who have untreated post-traumatic stress symptoms, the issue starts, there's a dilemma that emerges now, because the body naturally reminisces about the past. There's something about getting to that stage of life where you've lived quite a few years and you have less of those years ahead of you, that the body naturally starts, according to Erickson, reflecting and reminiscing about the past. Now, this in and of itself becomes the dilemma that I'll be talking about with traumatic stress. Because as aging trauma survivors, as trauma survivors age, their reflection on life, if they have unresolved traumatic stress, may create a problem with them succeeding through ego integrity versus despair. Because where someone is in their stage of development impacts on the traumatic event response. So the age of the survivor, what age they were traumatized, the counseling goals in terms of their ability to forgive themselves for making certain choices at the time, unresolved issues that they're still sitting with, like in the video with that World War II veteran, and struggles with relationships. Like, are these counseling goals for them? Is this something that they would like to accomplish? But if eventually at old age, are we able to help facilitate productive reminiscence, which would then, according to the literature, lead to optimal aging? So going back to integrity versus despair, let me talk a little bit more about this particular stage of development. So we have traumatic stress among older adults. So I'm going to talk now, I'm going to so forgive me if I'm going to be jumping from developmental and traumatic stress. Eventually I'm going to bring this together. But as I was working on this proposal, I was in the PTSD literature looking for things about aging, and there was not a whole lot. And so then when I went into the gerontological literature, which I needed to do because I was trying to develop a proposal of doing a PTSD intervention, I first started thinking I was going to work on, like, my working hypothesis was, oh, I wonder if Vietnam veterans, now that there's at this over 65 age group, that I would probably, they'll be experiencing more losses in their lives. And the last time that they experienced this kind of loss, these sudden losses, would be in Vietnam. So I thought that there was a connection between this stage of their development and potentially triggering aspects of grief and loss. As I was delving further into that, I ended up finding this whole issue of reminiscence and life review. But I do want to back up a little bit more, back to this whole issue of traumatic loss, because traumatic events do include numerous losses. It's the physical losses of human life, personal property, personal relationships, a job, a home. But there's also the hidden emotional losses that traumatic events also include, which is a relationship role, a dream, a fantasy that they may have had about what their life was going to be like. They lose the sense of immortality, because that safety bubble that oftentimes we walk around with until a traumatic event happens, you've lost that now. The invincibility and safety that I was talking there in that bullet. And then the assumptive world, which some of you probably know about, is the loss of the assumptive world. That belief that the world is good, the belief that I am, good things happen to good people, and then and that the world is organized and safe. That's the assumptive world paradigms. And so what happens is people lose that when a traumatic event happens, because it violates all of those. And then also just the naivete and blissful ignorance about life and death. Once somebody's traumatized in terms of personal safety or life and death, then that changes for them. So they kind of lose that perspective. And then in addition to that, there's different types of grief, right? And I don't have to read these to you, but you can see that there's all different types of grief. But aging also includes numerous losses. So we have traumatic events have losses, and aging includes numerous losses. So there's this issue of, what if somebody doesn't learn how to grieve? Okay, so I've worked with lots and lots of veterans in the past and clients in the past where they were never role modeled as to how to grieve. Like, there was either they weren't exposed, they didn't have an opportunity to grieve, or somehow as children or young adults, the ability to grieve was not allowed due to their circumstances. And so war veterans oftentimes end up falling into this category because, due to the situational issues around the war zone, there is no time to actually grieve and provide any type of connection, ritual connection. So there's no role modeling, and they make assumptions about grief. So if somebody doesn't learn how to grieve, they make assumptions about what grief is, right? So it's like, oh yeah, this is just people just crying, and I'm not about to do that. And so they deny their own permission to be able to actually have those grieving emotions. I've run into clients who consider normal grieving as abnormal. and also then say, oh, well, that's something for them to do. They defer grief to others. They can do that, but that's not something I'm going to do. And so the previous experience of a survivor impacts on the traumatic event response. So this is the full lifespan approach to actually treating traumatic stress. So oftentimes, and I'm a social worker, by the way, and so I think about the full life context a lot. I also think about the person and environment connection and all of that. And so what happens is that I found that, and working at American Lake VA really helped me think about how the full life perspective provides the context that we need to be able to actually work most efficiently with survivors. So there's the childhood aspect. So what kind of social supports, what kind of values and cultural beliefs and rituals was somebody brought up with? Did they have any previous traumatic events, and at what developmental stage did that happen? So understanding, because the childhood traumatic events will probably influence on how subsequent traumatic events occur for somebody in life. And it kind of echoes back, right? And so, or somebody wasn't traumatized in childhood. They had a wonderful childhood. They had a healthy childhood, and then they get traumatized. I mean, either issue, previous trauma in childhood, and then a really horrific traumatic event in young adulthood, for example, versus no trauma in childhood, pretty uneventful childhood, and then a traumatic event happens. Both of those, you can see, would provide a fuller context as to how somebody responds to the traumatic event subsequently. But also then the circumstances surrounding a traumatic event. Again, developmental age, the societal beliefs about going through harrowing traumatic events. And the social supports before and after, were they available at all? Going back to societal beliefs, I mean, working with World War II veterans and how society treated them as they were wandering around with traumatic stress, and Korean War veterans and Vietnam veterans versus the veterans now. You think about it. Our society treats trauma survivors differently than they did before. There's been a major shift of more sort of understanding and thinking about it and less pathologizing of it. Whereas prior to our current wars, and especially 9/11, because 9/11 actually ended up being the juncture where the tragedy of 9/11, 2001, actually ended up being the juncture where non-trauma survivors actually started to understand traumatic stress more so than prior to that tragedy. So that's also contextually informing, because it also says to somebody, the survivor, it tells them how much permission they did or didn't have to be able to disclose that something horrible happened to them. And then the type of traumatic event: interpersonal trauma, war trauma, natural disasters. So does PTSD make grieving more difficult? I think perhaps so, because the PTSD symptoms seem to actually have elements of stuck grief embedded in them. For example, if we think about sort of Kubler-Ross's stages of grief and loss, as probably everybody already knows, there's anger and fixation on control, difficulty with full range of emotions, intrusive memories of the loss, thoughts of I should have done this or I shouldn't have done that, and lots of guilt for making the choices that they made at the time of the traumatic event. That's kind of like bargaining and anger combined together and bouncing between those two stages of grief and loss. But then there's also depression and low self-esteem. I didn't do the right thing, for example, therefore I'm unworthy of feeling okay. So there's that loss of the assumptive world. And then hyper-startle, hyper-arousal, social isolation and avoidance, the trauma-related nightmares and sleep problems. So there might be unresolved grief embedded within the traumatic stress symptoms that get presented to us as practitioners. So one of the things that I think about is it's important for us to think about the context and then the context. It's like layers of context, if you want to think about it that way. So we think about the context of the trauma memories in addition to the developmental context that I was talking about before. But how often a client still experiences memories, really try to get a sense of that. So instead of just hearing that they have memories, I assess a lot. I've been an over-assessor for a long time and have never regretted that. But how often a client experiences, what are their current coping mechanisms? So assessing for frequency, how long it's been going on, was the first time, last time, and how long it lasts for when an episode occurs. So, and what are their coping mechanisms? Have they done any past work on their traumatic memories? Has there been what types of experiences prior to the incidents, violence, betrayal, helplessness, and grieving? Do they have social supports after the incidents? So is there any methods for them to be able to cope with these things? I mean, all of these are part of providing the context, like what has been there for this person, and every single person is unique. So this is one thing I don't have necessarily a slide about this, but for this presentation, but I've practiced and I feel like I have liked doing this. And so every trauma survivor is unique and they have their own unique version of traumatic stress. So going back to this aging issue, which is not a small issue, which is the dilemma of aging in PTSD. So I briefly mentioned before about Erik Erikson's integrity or integration versus despair, or ego integrity versus despair. And so here becomes this dilemma of aging in PTSD as it sits with natural reminiscence, which is traumatic events are so horrible that a survivor doesn't want to remember it. And traumatic events are so horrible that a survivor cannot forget. So reviewing that, aging and reminiscence start coming together. And so when we're talking about reminiscence, we're really talking about the natural inclination to think about the past, to have memories. And believe it or not, there's different kinds of reminiscing. And so when we look at Erikson, here's the first bullet: life stages, older adults, there's the positive revolution of the final psychosocial crisis, ego integrity, sense of a positive concept. So that's what we're going for. We're going for ego integrity. But reminiscing, according to Butler, is part of aging in older stages of life. Prior to Butler in the early 1960s, people used to shut down grandparents and elderly neighbors saying, yeah, that's the past. You don't have to talk about that anymore. And then Butler came in the early 60s and said, no. I think this is actually helpful to them. I think these stories that we hear from older clients and patients is actually helpful to them. It actually helps people prepare for the end of life. So we should encourage people to talk about and tell us their stories, because it's part of this integration process. It's part of them taking these memories and integrating them and doing something with these memories in a productive way to help them prepare for the end of life. So there are different types of reminiscence that can contribute to either this successful aging or this not so successful aging. And that's, so the not so successful aging is sad, angry, and what's called bitterness revival, which is regrets, things that clients would want to change, and they kind of generate these kind of memories over and over again just to, in order to like kind of keep that edge on. However, if that's the kind of reminiscing that predominates in somebody's natural aging reminiscence, what happens is that they are likely not to age successfully. They are likely to be more socially isolated, and they are not going to pursue what the gerontology literature talks about called optimal aging. They will not be, they will be more depressed, more isolated, and grumpy, to put it bluntly. And we actually found in the literature, even like 25 years ago, that war veterans with PTSD actually have not been aging well. Paula Schnur, back in the early 1990s, did a literature review. This is a while ago. It's like, I don't know, how many years ago is this now? And she found that there were problems with mental health readjustment and PTSD, and that there was a clear lack of assessment and treatment of PTSD among older veterans. And back then, she was focusing on the World War II veterans and the Korean War veterans. And then down below, Brooks and Fulton, 10 years later, found data in the 2001 National Survey of Veterans that Korean War veterans showed poorer mental health than those who were not in the war zone. PTSD rates were higher by 5.5% than in the US population. And then a few years later, Chatterjee found that actually suggested a comprehensive lifespan model of long-term effects of military service on physical and mental health, and said that veterans who previously functioned well experience increased combat reminiscence and emotions later in life, which again talks about how this natural reminiscing happens. And I can tell you that from working in the PTSD programs that I've been working at, that when people retired from work, the war veterans retired from work, sometimes their reminiscing about the war actually had a second wave. So if they were able to kind of keep it at bay while they were in their jobs and had families and were raising kids, then suddenly all of that changed. And we had this influx of older veterans coming in who were just retired, and they found that their PTSD symptoms had been researched or actually appeared for the first time ever, and they didn't even realize. So there is this reminiscing aspect that kind of bubbles up. And then just as a sidebar, Yaffe found in 2010, with an N size of 181,000 people, that veterans with PTSD had a 7-year cumulative incidence of dementia rate of 10.6, 4% higher to those veterans without PTSD. But when you have 181,000 people and you actually have a 4% difference, then that's a lot of people who are coming up with PTSD and dementia versus not just dementia. And so the reason why I add this particular literature, this particular study, was not only it was a correlation study, which meant you can't say causal effects here, but you can say there seems to be a higher correlation between these two things. Perhaps if we actually help people with their traumatic stress memories and help treat their PTSD, perhaps we're indirectly also reducing their risk of dementia. And if you think about how often people get triggered with PTSD, with all of the endorphins and adrenaline that accompanies that hyperarousal and lack of sleep and nightmares, if you think about that, that does take a toll over years and years and years on somebody's nervous system. And so one could argue, logically at least, that if we help people work through their memories of their traumatic events in a way that helps them live more comfortably with them, then perhaps we also indirectly help them not kind of flood their system with so many neurotransmitters and then help reduce the degradation of that system and potentially not have dementia. But there's a problem. So there's a little or no resources. So there's a lot of war veterans aging into their 60s, 70s, and 80s because Vietnam vets happen to be part of the baby boomer population. They're a subgroup of the baby boomers, and we have a lot of baby boomers who are now aging into these decades. And the VA healthcare system and vet centers are already overwhelmed because we have the existing older veterans and we have these newer veterans coming in. And so what is kind of unfortunate is that the VA has focused away from older veterans onto the younger veterans, which I'm saying it's as if they couldn't widen the scope and include all of them. It's as if all of the work is now focused on the current veteran population, which is okay. I just wish they wouldn't somehow like close the door against actually still working with the older veterans. And so this is part of what I'm advocating for by doing this study and doing this presentation, is really thinking about the issues that could fit for the older group that is not just treating veterans the way we've always treated them for 45 years. But there's a little very little integration between gerontological expertise with PTSD treatment efforts and vice versa. Very little integration of PTSD expertise with gerontological expertise. And I found this when I was doing my literature search, you know, several years ago, which was very few overlapped. And actually the slide before with Chatterjee, Brooks and Fulton, and that and Yaffe, that all was like, that was almost all of what I could find. There's more, but it isn't nearly what one would think, given how long we've actually been working actively with veterans. So there really was little or nothing in the literature about the impact of PTSD on normal aging, and even less on the relationship between aging process on PTSD, or how PTSD contributes to aging challenges and thereby impacting on optimal aging. But then, as I said before, we also have this, which is this woman saying in this graphic, I'm sorry, we're bombarded with aging boomers, come back in about 20 years. So there's a lack of age-appropriate PTSD treatment. So over 30 years, Vietnam veterans have been at the forefront of receiving PTSD counseling. Very few VA or vet center programs have prepared for an increase of treatment-seeking aging veterans, and there currently are no protocols for treating older war veterans suffering from PTSD. So, intimacy versus isolation, and ego, integrity versus despair. Just to review this again, the Vietnam veterans who are now in their older years, heading into 70s and 80s, they were traumatized while they were young adults in that psychosocial developmental stage of forming intimate, close relationships with other people. Now, they have this issue of the natural reminiscence occurring and the memories. So Vietnam veterans actually face, and baby boomers, let me expand that to baby boomers, trauma survivors who are baby boomers, face developmental changes, entering integration versus despair, which has this natural reminiscing element, with unresolved traumatic memories that are unwelcome and intrusive. So this task can be actually daunting for those veterans because they have memories that are naturally coming and intrusive memories of traumatic events. So just to show you this graphic here, starting from at 12 o'clock, so older adulthood, integrity versus despair. If you go down to like to the right, it's a natural inclination to reminisce about the past. But if they have unresolved PTSD trauma memories, which include intrusive memories of nightmares of painful events, there's a negative self-evaluation that's often accompanying those memories, a self-denigration, I'm not worthy, I'm not good, I should have done something different, and thereby avoidance of thoughts and memories, because all of that generates a lot of sadness. And if you focus on here in the red circle, you can see that all of these are about the memories. And here in this yellow circle, here is the dilemma of aging and PTSD, the natural inclination to reminisce and the avoidance of thoughts and memories about the past. Reminiscing, avoidance, reminiscing, avoidance. So what we know is that war veterans are traumatized during intimacy versus isolation developmental cycle. Society had and has a limited tolerance for survivors to grieve openly, and war zones further challenge any opportunity to grieve. Baby boomers, including Vietnam vets, are aging into integrity versus despair. Veteran-centric agencies, including VA, are overburdened already. There's evidence of older vets not aging well, and there's scant research on any interventions for aging war veteran trauma survivors, and probably even less on aging trauma survivors, whether they're veterans or not. So is this actually happening? That a traumatic memory disrupts one's ability to consolidate one's life story in a coherent fashion to a point that it disrupts optimal aging. Well, this is now where we get to life review, reminiscence, aging, and war-related PTSD. But I'm going to pause here for a moment and see if anybody has any questions.
Very good timing, because there is a question in the chat box. It is there a correlation between lack of PTSD treatment and older people accepting they need help, or even being aware they are suffering from PTSD? Asking for help equals weakness.
Yeah. So I can't tell you what because no one's written about that particular aspect that I know of, but there is resistance, right? So people are able to live comfortably enough up until a certain point. But if you think about it, so maybe somebody's been able to live with the traumatic stress issues up to a certain point. But when they age into their 60s and 70s, this natural reminiscence might confound somebody's, like it might actually up the ante, so to speak, in terms of memory generation. So in addition to the intrusive recollections that are, one of the hallmark symptoms of PTSD, these daytime intrusive recollections, as well as traumatically based nightmares, there might be this other ramping up of reminiscing from all parts of their life. And so, of course, there's lots of people who feel like, well, I've lived with this long. And if I start addressing this now, that means I'm weak. I can't handle this myself. And then there is, and of course, with war veterans, you do have that element of machismo that oftentimes creates a barrier between them, getting treatment and not, right? And so then they have access to resources, but they don't access those resources because there's something about doing that feels less strong. I will say that I recognize the amount of courage that it takes for people to walk into a counselor's office. And I oftentimes would recognize that because you are actually, the clients are actually having to back off of that thinking about themselves, like because it can become problematic. But it really is, I mean, I just don't really know how to directly answer the question except to say there probably is going to be resistance, especially the older people are going to be more resistant. I mean, when I'm talking about this group of Vietnam vets, I can tell you those guys were not like openly embracing coming into the group because they didn't know how it was going to go. And so, of course, there's always going to be some resistance to outreaching to a practitioner and saying, I'm not sure if I'm handling this as well as I could be. I mean, there's a lot to that. And I think the older that people get, the less likely they are to do that outreach, because then the new rationale is, oh, I've lived with it this long, I can make it to the end, or it's too late, or I'm too old. I mean, certainly there's always going to be some messaging of why not to do it. So building rapport, if somebody does finally get to a point where they do reach out in some capacity, and it's not unusual actually people to have a medical issue emerge that then gets them to, like the medical practitioner might hopefully assess and say, this might actually be more stress related. And so then to help somebody actually kind of nudge them towards actually working on traumatic past might actually be helpful, but it's going to be this indirect route if somebody gets there at all. Really hope I kind of answered that question as best as I could. Is there another question? Oh, okay. I'm back on here. Is there a difference between genders dealing with PTSD and aging? I'm going to say no. I'm going to say yes and no. Let me do that. But for the most part, the women veterans that I worked with who were older Vietnam veterans themselves, they still struggle with it. But it's everybody's so unique. So I think that women have a tendency to be more comfortable sharing because we're socialized to do that to some degree, right? And so it kind of might work that way, whereas males are socialized by our society to not communicate feelings and thoughts and, right, just suck it up. And so I think that there is a setup of not giving permission to men more frequently than women to be able to share. So I think there would be an issue in terms of how they age differently. But I think women who are trauma survivors have their own kind of resistance, right? And it also depends on sort of the type of trauma and what happened and when it happened. I mean, all of that, again, also plays a role. So there's no quick answer to that particular question. Other questions? Okay. So so how about, are you guys clear as to sort of this whole developmental and PTSD? And did I lay out the dilemma okay enough? I just need a few nodding heads. I only see a few of your screens. Okay. Just wanted to make sure, because that really became sort of this aha moment for me. And when I was realizing, yeah, thanks for answering the question. When I realized, I was like, wait a minute, this isn't necessarily something that people are thinking about. But the gerontological, in gerontology, they think about this. In gerontology, they talk a lot about helping people reminisce and do what's called facilitated life review. So this is my Hartford study. And so this was about, I'm going to slow it down too, because I just buzzed through all that stuff and I want to have time for questions near the end. But I call it Life Review, Reminiscence, Aging, and War-Related PTSD, learning from 2 groups of Vietnam vets. And so as I told you before, I was very fortunate to get invited to be one of the VA Hartford geriatric social work scholars between 2013 and 2015. And in that time, I was actually also able to not just propose and get through IRB, but which is a big to do from a vet center especially. But I actually did then develop one of the very first, if not the very first, vet center study that was actually housed in a vet center from start to finish, not just someone from the outside accessing vet center clients, but a vet center counselor conducting a research study. And so actually, when I got selected to do this, I realized that one of the things, and I talked to my social work student about this, one thing we realized was that PTSD treatment at the vet centers at the time were pretty much identical since the 1980s, right? So vet centers were created in the late 1970s, these community-based outpatient programs funded by the Department of Veterans Affairs, and out in the community, not attached to a hospital. And so, you know, they'd been doing support groups and they'd been doing all of these like, you know, veterans helping veterans kind of milieu all of these years. And what happened was over the years, you know, a few things would come in and formalize it a little bit more. But for the most part, the approach to treating Vietnam vets was not that much different than it was back in the 1980s. So here we have older Vietnam veterans who are being treated just like they were when they were younger Vietnam vets. But given this whole developmental changes, it kind of made sense to shake things up a little bit and change how we actually treat older war veterans, because their needs and their connections to people and their developmental norms are different. And so, so I really wanted to understand this quite a bit more. And so what we did was we actually had this study. We did this study out of the Portland Vet Center in Oregon. And I had two colleagues, one of whom is from the Portland VA, the MYRIC, for those of you who know what a MYRIC is. And then I had a consultant from the Albany, New York, who was actually selected by Hartford to be my research consultant and also was an aging expert. So what we wanted to do is understand if a structured life review component superimposed on a PTSD group therapy would help reduce trauma survivors' disrupted reflection of past memories and to determine if a sequencing of groups has more impact. So I do have to, of course, thank all of these entities that help support this project, because this was no small effort, and I certainly did not do this alone. So I want to thank VA, John Hartford Foundation, Geriatric Society, Portland Vet Center, Geriatric Social Work Initiative, and Readjustment Counseling, because it would have been impossible to do this without all of them. So let me first talk about, and it seems like sometimes I'm going backwards and forwards, but that's just how I had to lay this out because there's so many things to talk about. But let me just first talk about the basics of post-traumatic stress focused therapy as it relates to PTSD symptoms. I'm not going to go through at length PTSD symptoms because my assumption is that you already know this, but I will have to use the PTSD symptoms to be able to illustrate my point. So bear with me as I go through this part. So as you know, part of what we do in treatment is that people have triggers, and I don't really know why this little X is there. But anyway, there's triggers, and then and the PTSD is actually maintained by efforts of when the triggers. This is sights, sounds, smells, and calendar dates, which match with when somebody was traumatized. So we also call those anniversary reactions, as well as physical sensations. All of those fall into the trigger categories. There's subtle triggers and there's obvious triggers. Most trauma survivors pre-treatment actually only know the obvious triggers. They oftentimes don't recognize the subtle triggers. That's one of the focuses of psychotherapy. And then what generates from when somebody gets triggered, it reactivates this whole cycle, which includes the intrusive recollections, memories, nightmares, and the feeling that this is happening all over again. Immediately along with that comes, almost coupled together, the physiological hyperarousal of being in danger, as well as distorted thoughts and associated memories from the original trauma. And then just on the coattails of that is avoidance and detachment, which is when people are like, I got to change whatever I'm doing right now, got to get out of here, remove myself, and then they quest for the mood shift. So that works pretty well initially, but what ends up happening is that they don't understand the intrusive recollections part. So this avoidance pattern is what maintains traumatic stress. So the intervention that we tried to do, at least when I was in full practice, was to intervene at the junctures of physiological hyperarousal and intervene at the juncture of avoidance. Because those two things, although it's a hardwired in survival mechanism, is not having utility any longer in the survivor's current situation. And because the avoidance has its, if you're a behaviorist, you'll love this. If the avoidance has some sort of reinforcing component, which is I now no longer feel anxious, which is the reinforcement for detaching and avoiding, then they never get a chance to reassess the issue of like, okay, what is this? How do I kind of retrain my wiring? How do I change the wiring around so that it's updated to realize that this is not an identical situation? So this is kind of how PTSD kind of stays active and reactive over and over again in someone's body and mind and thinking, and emotionally especially. So if we think about intervening and saying, providing a safe space for people to do their work, then we actually then help them no longer have to avoid, and thereby we give them a space where they can actually talk about these intrusive recollections, these interrupting memories, as one of my clients said once. Interrupted. It's like it's so rude, right? These like out of nowhere in the grocery store, or driving down the street. So anyway, so that's part of like the emphasis of like understanding triggers and understanding what maintains these intrusive recollections. So in the PTSD field, how we intervene is through individual psychotherapy, group psychotherapy, medications, some evidence-based interventions, action therapies, and creative art therapies. So just to let you know, I know CPT, been trained in CPT and EMDR from a long, long time ago. Group psychotherapy and individual psychotherapy is mostly how I've practiced. I don't prescribe meds, but creative arts I've used, and also action therapies like Outward Bound have been utilized and integrated as part of the practice that I've had throughout my career. And so these are all sorts of ways of trying to creatively help somebody get unstuck. And in the gerontology field, interventions look like this. It's really, again, focusing on the developmental stage of integration of memories and reflecting on memories of one's life. And so in the gerontology literature, they talk about life review, facilitated life review, or these open-ended, sort of loosely formatted reminiscing groups. So again, attempting to merge these two interventions together, what we did was focus on the issue of memories. So memories of the past are the focus of both. So we combined two interventions from two disciplines with two groups of veterans. And this is where we combined group therapy, PTSD group therapy, and facilitated reminiscence through life review. Again, a lot of the narrative during our life review was on this. So I'm going to describe for you now on how I actually did the study structurally, just so you understand that I crossed my T's and dotted my I's as a researcher as much as possible. But I also will talk to you about how I actually did this process. So part of the consultation that I got was I really wanted to focus on Vietnam vets. I had actually started as a practitioner in the late 1980s working with Vietnam vets while they were still in their 30s and 40s. So I literally had been following around Vietnam vets throughout my career, except for when I was at the Portland Vet Center. Then suddenly I was in this other role, and I was working with a whole wide range of veterans, not just Vietnam veterans, but everybody from all sorts of decades. And so my day was filled with 20-year-olds and 40-year-olds and 70-year-olds and 30-year-olds. And so it was just, that's how my role as the MST counselor played out. But when I did this proposal, this study, I actually ended up re-engaging with Vietnam vets, who are my original client group when I started my career with the VA. And so what happened was that it was fascinating, actually, to have re-engaged with Vietnam vets after taking a respite from this particular treatment group. And so I wanted to help them, help the VA really, and veterans figure out how to create an intervention that matched with their needs developmentally. So I actually was I was a counselor at the Vet Center, and because of my role, I actually didn't do any Vietnam vet groups. I had no war veteran groups. My groups were around sex assault, and so I had 2 women groups that I was facilitating at the time, and then I had a lot of clients. I had over 45 active clients at any given time individually, in addition to my 2 groups. And so, of course, I added 2 more groups, which is the study groups. But because I had that role in the Vet Center, I didn't have to actually, it was actually fairly easy for me just to approach my colleagues at the Vet Center who were doing war veteran groups more regularly, and just invite them to refer people to this study. And the Vet Center staff was amazing. They were awesome and super supportive. And I had been telling them what was going on the entire time. And so I actually didn't have, I wanted to have veterans who were relatively new to therapy, Vietnam vets. They couldn't be, they had to be obviously of a certain age. But I can tell you that this kind of format will work with younger veterans too, or will help younger veterans also. But because it's a gerontological intervention, I focused on the older vets. And then so I invited them to refer people to me. So none of these people could be on my caseload, etc. So the age is between 64 and 71. And again, this is a few years ago. And as people were coming in and being referred, I would send them to somebody else to go through the informed consent. They would do the informed consent with me. That's right. They'd do the informed consent with me. And then I would refer them to the psychiatrist colleague, my co-PI for the study, and he would do the measures because I was going to be the group facilitator and he was the assessment guy for the measures. But everybody had a pretest, and then from that pretest, they actually they were randomly assigned into one of two group conditions. The first group condition would have been, they had a 50-50 chance of being in this, which is a life review PTSD group. I was looking for 6 veterans to go into that group for 24 sessions. That means if they pulled the envelope out of the hat that said that they were in this group, they were actually going to receive autobiography, which is another name for life review, prior to going into regular here and now therapy. So the other group, if they pulled the envelope out of the hat, then went into a here and now PTSD group, which is really exactly how all of the other war veteran groups were being facilitated. People would come in, they'd check in, hey, how's it going? Anybody got anything to talk about? And then people would talk about situations that are going on right now. And then maybe through the session, they would have a connection between past war incidences or past traumatic events that would then somehow be contextually part of what was going on with them now. Whereas the other group, the life review and autobiography group, was specific to, we are going to talk about your life from birth all the way through childhood, and then from childhood through all the way up until military, actually. So it all went up, and then military, and then post-military. And actually, this is how we used to do our war trauma focus groups at American Lake when I was in residential treatment. So I knew that this structure could work with Vietnam vets because I had seen it done while they were younger, back in the 80s and early 90s, at the American Lake VA residential treatment program. So this slide here is just showing you how the groups were then split. So 6 veterans in each, 24 sessions were provided, and then we did what's called a crossover, which I'll talk about. So the initials are LD, which is me, and JB, which is Jim, my co-PI. And so we split who would do the assessments. I could never see the assessments. I was not, once he assessed them, they were locked away for a year. I couldn't, 9 months to a year. I could not see or know anything about how the veterans did on the assessments. So if anybody's really wanting to geek out with me here in terms of research, I'll just tell you, here is the information. The research design was called a randomized 2-group repeated measures crossover intervention outcome study, mostly quantitative. Data collection was every 3 months. So although they had 24 sessions, they were actually measured in between their time in their current group. And then as we did the crossover, I did all sorts of data analysis, and participants were recruited from the vet center. They were not on my caseload. So it was unfortunate because some of the Vietnam vets on my caseload really wanted to come into these groups, but they couldn't because it would taint the study, so to speak, in terms of the group itself being the intervention. And then also, these are all just the logistic stuff. Veterans pulled an envelope that randomly assigned them after they had consented and done their measures. And once 12 veterans had been recruited, I actually started it took only a couple months to actually, well, July, August, September, October. It took about 5 months for me to get 12 veterans to agree to the study. And you know what's fascinating is that I was reminded about the benevolence of Vietnam vets and how they are willing to take a risk for the benefit of other people. On at least 2 occasions while I was consenting the veterans for the study, and informed consent, telling them all the risks and all the benefits and how it's going to look and what they're getting themselves into, twice at least, the veteran would ask, is this going to help out those younger war veterans? Do you think that this might be able to be helpful to the young war vets who are coming back right now? And I would say, I hope so. And they said, okay, I'll do it. If it's going to help these younger guys out, these younger women, then sign me up. So it was very, very touching to be reminded of that. And so then the group intervention started. They started on the exact same day. And different times. I created a 2-hour gap between the 2 group meetings because I didn't want them hanging out in the waiting room talking to each other. I wanted them to be completely separated throughout the study at least. And then after 6 months, after the group stayed the same, the membership of the group stayed the same, but I changed my facilitation of the group. So after the 6 months was over with the autobiography group that had gone through their entire life, then I switched to the here and now format, and the here and now format folks went into the autobiography format. So I structured them differently, which is called a crossover design. And the crossover design kind of looks like this. And so this is how you can see it. The hybrid group in this graphic is the same as the autobiography group. I call it hybrid because we were doing PTSD therapy in the context of doing the autobiography. So it was like a hybrid, a double group, and then the regular PTSD group. And so here are the dates. I guess I started in 2012, late 2012, and then the groups ended, as you can see, just shy of the 13 months later. And then I waited 3 more months with no group meetings. And then they did their measures one last time for any type of residual post-group effects of the groups. And then I convened the groups again. So in April of 2014, literally a month after the last post-intervention assessment, I actually brought both groups together, the guys who wanted to be in group again, and I had most of them stay. And they came together, and it was interesting because the first group meeting, one group was on one side of the room and the other group was on the other side, and I was the only one sitting in the middle. And I was like, and they, again, it was like brand new group, right? They didn't know each other. They had known that the people across the room were in group with me all this time, but they were like, we had to build rapport all over again between the group members. But within a month, they were intermixed in the group room together. So let me just go backwards and tell you a little bit about how this group looked. And specifically, I'm going to spend more time talking about the life review / hybrid / autobiography group, which did what's called facilitated life review. So facilitated life review in the gerontological area is really about sitting down with somebody and having them talk about their life from birth all the way up until now. Each session, so I would have the group together, so me and the 6 veterans in the room, and each session we would do what's called a round robin feelings check-in. Both groups had this, by the way, where I'm an emotion focused therapist, and so part of what I was trying to also get veterans to start doing is no longer detached from their emotions. So part of intervening at that level is the simple check-in with 2 to 3 emotions of which they're most in touch with. Emotions, not thoughts, and with no follow-up of explanation as to why they feel this way. I'm frustrated because somebody cut me off in traffic. I'd say, okay, so you're frustrated. What's 2 more emotions that you're experiencing right now? And I would hand out that little, what are you feeling today sheet? And I would bring it to almost every group session. And if they got stuck, I would hand them the sheet to help them. And they didn't like it at first. And then eventually they were okay with it. Again, there's that resistance. This is not something I'm used to doing. I don't like this. But it was part of actually treating the PTSD early on, which is to get them to reacquaint themselves with their emotional part. And so each session, vets checked in with 2 to 3 emotions that they're most aware of at this moment. Again, also just getting them to practice about tuning in to their emotions on command. So that way, when they're in a situation that they're triggered in or whatever, to have them start thinking, okay, what emotions am I most in touch with right now? It's a small thing, but it actually really has sort of a large effect over time. Veterans were given open-ended questions about their pre-military lives. And because they were veterans, it made sense for me just to couch it as pre-military, military, and post-military. I would actually chunk these questions out in groups. So on the very first session, as we were talking about PTSD, because the very first session, I talked to them about how I thought about PTSD and how I think about PTSD treatment. And that little miniature psychoeducational session where I showed them that diagram I showed you about PTSD with the kind of the triangle and the X's and stuff like that. Just explaining that to them helps them kind of like ground it into, okay, this is what we're focusing on. But also it helps me provide an argument for why they're going to experience me as a facilitator in a certain way. I explained to them, I'm an emotion-focused practitioner. I will be asking you about emotions. And there's a reason for that. It's not because I'm trying to dig under your skin. It's because I think about traumatic stress as also being avoidance and detaching from emotions to a point that you don't have self-awareness as to how your body is trying to help guide you into recovery. And so just educating them and grounding them into this also helps avoid surprises, because trauma survivors don't like surprises. And so I just try to forecast enough for them so that way they know in group, this is how you're going to experience Lori. And so what I would do is I have this stack of pre-military open-ended handouts, right? And I have all these open-ended questions that were related to what's called the life review experiencing form that some nurses actually created for their facilitated life review groups. So I just borrowed from that, changed it up a little bit of the words, and then ended up distributing it out on the first day after I did my PTSD education talk with them. So I passed them out. So then that way they could make it whatever they wanted to. So I provided spaces underneath each of the questions that allowed them to write in their answers if they wanted to. And then they could bring that sheet of paper with them when it was their turn and then use it as a guide sheet. Some veterans didn't. They used it as a guide sheet and then rolled it up and then ended up just talking. Some people actually brought in, I said you can bring in photographs and memorabilia. You don't even have to use the sheet if you don't want to. Just gotta give you some starter, like sort of what we're interested in hearing about. And so I let them own this. But I said, here are some questions just to help you get started, or you could use it the whole time. One veteran actually would unroll it after a while and he'd go like, oh my gosh, I'm totally off. Okay, let me see what else I wrote down here. So I just let them have the session time for them to tell their story. And we did it in a round robin style. So again, first session, psycho ed about PTSD, psycho ed about me, how they're going to experience me asking questions, passing out the pre-military forms. And then I said, okay, we need to have a rotation of who's going to disclose during one session, because each veteran had one session for pre-military, 1 to 2 sessions for military, and 1 or 2 sessions for post-military. So for 6 veterans, 4 sessions were assigned to each of them. That's 24 sessions. And the reason why to have that, I said 1 to 2 for military or 1 to 2 for post-military, was because I anticipated the possibility of us having to, while in military, do some war trauma focusing processing within that part of their life. And so I allowed that to be a possibility in the military section, or they could use that floating session for their post-military. And the reason for that was it'd been 40 years since they left the military. So there's a lot of time that they would be talking about, and chances are they wouldn't get through it in one session. Each veteran was given 1 session of pre-military. So the first veteran would say, yeah, I'll go first. And then the second veteran, okay, I'll go on week 2, week 3, week 4, week 5, week 6. Okay. And then what we also did, and I would advise this, is if session 1 is like Joey and session 2 is Ernie, then what we would do is I'd say, okay, Joey is scheduled to speak during our next session, but Ernie, you need to be ready to go just in case, because if Joey gets sick or has car problems and doesn't come in, you might end up taking that session. And so I always had a backup because we couldn't lose rhythm for numerous reasons, mostly because I didn't want the momentum of the group to change if somebody got ill or something like that. And people did get sick. And so that does happen. So always have a backup. And so what was interesting was that Ernie would make sure that Joey was showing up before group because they didn't want to be like I'm scheduled for next week. So are you coming? So they'd actually text each other or call each other and make sure that they weren't going to have to be prepared. But anyway, so always having a backup was helpful. And that kept things kind of going, and for us to always know full transparency. And so we went round robin with pre-military. And then on the 6th veteran's disclosure of pre-military, I had my stack of military open-ended questions ready. And then I would pass it out after that was over. I'd say, okay, here's the military history. And then we went in the same order with military. And then, again, last veteran with the military disclosure, getting out of the military, I had my stack of post-military questions, and then I passed that out. So that was a long time on that one slide. But they all took turns for several weeks. And so just to focus a little bit more on the facilitated, they each had 1 session for pre-military. And these are the kinds of things that were going on for these guys when they were growing up, right? So they were, you know, born in the 40s and being raised in the 50s and early 60s, right? And so they had this. So these are the kind of things that we'd hear about. It also was an amazing connection because of the overlap of time with the Vietnam vets. And then they had the 1 to 2 sessions for military. And these are the kinds of situations that we would hear about. And also, just to let you know, I had to create the adulthood questions military-wise, because what happened was that the LREF, the Life Review Experiencing Form that I had used for the pre-military and post-military actually didn't have anything about military in this form, which is interesting because they'd been using it with all sorts of people for a long time. So in italics are the questions that I added to the military questions that I distributed to the veterans, because these were the questions that would help talk about their military and more specifically their war experiences. So so I had to addendum the LREF in order to get the information during this part of the disclosure. So as you can see, I'm really trying to also make sure that they know by reading these questions that talking about traumatic events is okay in this group. Telling their story is okay in this group. And trust me, there was a lot more questions that would be generated by me as a facilitator of the group once a trauma was discussed. So although somebody might start talking about the traumatic event, how long they'd been in country when this happened, oftentimes once that disclosure occurred, then I would step into my facilitator role and I would ask many, many, many more questions in order to best understand if this is one of the traumas that is continuing to bother them into their current age. And then again, as I said, 1 to 2 sessions post-military, we would think about, it would talk about sort of how their Vietnam War experiences would continue to be a part of their lives. So on the same days, in the afternoon, I would also facilitate a here and now regular PTSD group. And again, we would check in with emotions and feelings, same type of resistance, same type of eventual acceptance. And then we would just start from there. I would ask them as they were checking in with their 2 or 3 feelings, I would say, would you like some group time today? And that's when they would like put in a reservation. Yeah, I got something I want to bring up today. This way we make it all the way around and everybody gets a chance to talk. I would not, so I would semi-structure the opening of groups specifically so A, they identify with emotions, and B, they say, yes, I've got something to bring up today. I got something to talk about. And then I'd say, okay, give me like 2 keywords, and I would write it down, and then we'd go on to the next person. Or they would choose, so the way I do it is I go, whoever volunteers to check in first chooses which direction of the circle we're going in, left or right, and then we just go all the way around, whichever way. And then the vets who say yes, if there's more than one, they negotiate. Okay, you guys decide. It's your group. You guys decide who's going to go first, who's going to go second, who's going to go third. And then we would start talking. And that's how the Here and Now groups went for the 6 months. And then once the autobiography group was done, then I switched and then did the same thing with the afternoon group, same group of veterans, but then I would give them the sheets and they would do the autobiography. It was interesting because when in the Here and Now group, one of the things that I observed was that the veterans would defer any type of disclosure about what happened to Vietnam to the other 6 months. They'd be like, well, yeah, this is going on with me and my wife, but and it probably has to do with this incident, but I'll wait till the next version of this group to tell you guys about it. And so it was interesting how often that would happen because their awareness about having this life review part, this autobiography part, they sort of like said, okay, well, I'll defer that for now to that. And I'd be like, well, you can still talk about it now. They're like, no. I think it'll be better for me to wait. And so they would. And then, so I'd have to make a note saying, okay, don't forget to ask them about, but that's how that happened. And then also, their anxiety about telling their story was interesting. This group, this regular Here and Now group, their anxiety about telling their story increased as we got closer to the crossover junction. Like they became more nervous because they knew that there were going to be questions. Even though they hadn't talked to any of the other group members from the other group, they knew that there was an expectation that they'd be telling their story. So anyway, so as you can see with PTSD counseling, the goals would be to reduce PTSD symptoms, reduce depression, increase social support, which is why a group makes sense, and to provide a safe environment with which to discuss emotions that are keeping survivors stuck, including grief. The goals of life review counseling are to shift from a bitterness revival version of reminiscence to hopefully more integrated reminiscence, to also increase life satisfaction, to increase morale, and to facilitate one's narrative to identify where their life had meaning. The ultimate goal is optimal aging, better end-of-life preparation, and an ability to let go easier when it comes to the end of life. That's really what it's about. So all of these were actually measured, each one of these, because I was looking at not only what the goals of PTSD counseling were, which is reduced PTSD, depression, increased social support, but also interested in thinking about how reminiscence might be changing, if life satisfaction is changing, if morale is changing. So the 3 research questions were, do these scores on these outcome measures change from pre-testing to post-testing 1 year later? And these are just quickly, those are the measures that were looked at. I'll talk about those in a second. And then also here, you might have noticed, it's like, oh, she did 6 months of one and then 6 months of other and then reversed it. It was like yin yang, right? So does the sequencing of the group conditions impact scores on these outcome measures? Does putting life review before regular PTSD group, is that actually better for them? Does it actually help them more than PTSD group before life review? And to be honest with you, when I walked into this study, my assumption was doing the regular here and now group prior to the autobiography. I thought that that was actually going to have more benefits, because my assumption at the time was that, oh, the PTSD group here and now, that they could get to know each other a little bit more through that process. They're not new to each other and then telling this big story. They're actually going to have like 6 months of hanging out and connecting, and then they'll be more like prepared to go into this more intensive thing. Okay, so I didn't know. I honestly didn't know what the sequencing would look like, and that's part of what I said to the IRB. And then thirdly, does type of reminiscence, as scored on this reminiscence function scale, believe it or not, there's a questionnaire for that. There's a questionnaire that measures different kinds of reminiscing. So I didn't know that before this, but lo and behold, I found one, so I got to measure that. Does it change from problematic reminiscing styles, which actually could lead to like unhealthy aging, to more productive reminiscing styles, which then could lead towards optimal aging? And so I wanted to know if reminiscing changed over time, and then use this particular measure for that. So my sample was, I got 12 at the very beginning. I didn't end up with 12 veterans by the end of a year-long or 15-month study, which is an unfortunate outcome, but it's also the reality of longitudinal research. But you can see here the demographic. There were 7 in the Army, 4 from the Marine Corps, and 1 Navy. And then the range of years during Vietnam, 64 to 73, that's a good chunk of time, 9 years, and 9 out of the 12 veterans were there during 1968. And for those of you who've worked for the VA or for veterans for a long time, Vietnam vets, 1968 was a turning point year. It was during the 1968 Tet Offensive where things really went badly. And so, so most of these veterans who I was working with were there during 1968. The age at the start of the study between 60 and 71, and this is in 2012, by the way, so 8 years later. And then marital status, 2 were singled, 7 were married at the time, and 3 were divorced. But just to let you know, the single guys had been married at one time, or actually, yeah, I think there was, 2 single had never been married, but the married guys actually had, this was probably not their first marriage. Only 1 or 2 of them had been married only once. And then the rest of them had more than 1 marriage. 11 Caucasians, because we're in Portland, Oregon, and 1 Asian Hawaiian. And then all of them, or most of them, retired or unemployed at this point. And rank status while they're in Vietnam, 1 officer and 11 enlisted. And these are all the different measures. Because it's a feasibility study, I won't go into this, but just to let you know, these are some of the things that I matched up with the needs of answering the questions, but also the needs of the vet center. I wanted to be able to provide the vet center system, readjustment counseling, with information with which other vet centers could use. So if you're wanting to, if you're from a vet center, or even from a VA program, these are the measures that I chose for this study. I had 2 PTSD measures, one particular measure for depression called the OAHMQ, which is really, it lines up with the DSM criteria for depression clinically, so it's better than the Beck Depression Inventory in that way, and it also is for older adults. And then I wanted to look at geriatric morale, life satisfaction, reminiscing styles, subjective wisdom, and then I asked one open-ended question about forgiveness. And then I looked at, my data analysis included effect size, and for those of you who don't know, effect size is really, did this have an effect? That's the question. And so you do all these like, well, inputting, and then you tell the computer to calculate a certain thing, and then boom, it tells you the effect size, which actually says, did people move from where they were before this treatment to anywhere other than? So did this have a significant effect? And clinically, that's what clinicians want to know. And so I made sure that I did a data analysis around effect size, so that way practitioners who are not into research, not into numbers or stats at all, could at least understand, yes, this does have an effect, or no, this doesn't. And then the other stuff was really about statistical significance. But this is what the raw data looked like. I spent over like about a year, that's me in the corner there, about a year, and then taking from 12 veterans to 9. I lost 3 veterans in the following way. One fell out of the study very early. And to this day, I kind of regret not backfilling him in because we were at the end of the pre-military. It would have been great, but he left just before he was going to actually tell his story. He was the one veteran that I didn't consent for the study because I was out of town. So what happened, he came in, it looked like things were going to go well, but then he disappeared from treatment. Another veteran actually had a stroke and ended up trying to come back into treatment, but his rehab post-stroke was too great for him to actually come back to the study. He did end up returning to the then consolidated group, like over a year later. So he came back in like May, I think it was May of 2014, but by then the study groups had ended. But it was really great having him back. And I was sad to have lost him into the study group. And then the third one actually waited till pretty far into the study and then ended up not continuing. And so so by the end, I actually had to figure out how to use people's data or not use them. But anyway, the data analysis in itself was pretty daunting, but also kind of enjoyable because it helped answer a lot of questions. But I would like to provide, because most of you are practitioners, I really would rather provide a case example of how this reminiscing and facilitated life review can work. Because what I ended up realizing as I was immersed in these groups was knowing somebody's childhood history, even if it wasn't traumatic, helped provide that context I was telling you about so much more in terms of somebody's traumatic stress response in the war zone in this case. And so because I was able to hear things, and even the group members were too, but when you think about where somebody comes from, that they're not a blank slate before they get traumatized, and for those of you who work with war veterans, this is definitely the case, they aren't a blank slate. So what happens is that somebody gets traumatized, and if you only treat the symptoms but don't have the context, the ability to connect things together with a client is lost. And so what happens here in this case is I'm going to illustrate a case of how this played out especially well for this one veteran, although this is not the only time that this occurred. So Mr. B, I'll call him, came to the vet center because his hands started shaking and he couldn't do his job. And he actually had to medically retire from a computer company that he had been working with for quite a long time. And so part of the issue for him coming to the vet center was he couldn't hold a mouse. Like he had to move his cursor around, but he had these shaking episodes of which he knew nothing about. And then he couldn't like move the cursor accurately. And it was very, very frustrating. And so he was pretty new to therapy. He was going to, everybody still had individual therapy. Nothing changed. They're still seeing individual therapists, but they were coming to group. And so while he was working in vet center, he shared during his life review, this autobiography part, he shared that when he was about 12 years old, this is part of his pre-military, his sister was killed in a car accident when she was driving to go on a camping trip. And he was raised in this, he had like a bunch of siblings, but he was particularly close to this one sister. She was about 16, 17 years old, and they had an abusive father who was emotionally and physically abusive. And so, so the kids really bonded together because they had a shared problem parent. And so, so when the sister was killed, it was very, very, very traumatic for him, although he never thought about it that way. So he shares this story with us about his sister being killed. And and so he tells this furthering, which was their father decided that a way to show the rest of the kids, including the son, to avoid driving recklessly, blaming the girl for the tragic death, was to have this crumpled Volkswagen towed into their house, to their front yard, and left there. The father also had young Mr. B clean up the inside of the car one day that still had the blood from the sister's accident inside the vehicle. Mr. B was not aware that he was traumatized by having to do this task by his father. I mean, he hated it. He hated his father. He hated his father. And he said that several times. But he had shared during his military portion of his life review that he had often volunteered to fly in helicopters as a door gunner rather than clean out the Huey medevac helicopters. So he had told this story about the Volkswagen in the front yard and like looking inside and seeing it and this task that he had to do and just hating his father. But what he had started saying in his military was how much he thought about his dad and how angry he was at his father when he got to Vietnam. And actually, when he shared this is before I know anything specifically about his Vietnam history. I asked him, I said, did you realize that's a traumatic event in childhood? Did you ever think about it like that? And he said, no, I've never thought about it that way. I said, well, I can ask the rest of the group here, but I'm voting that was a traumatic event for you losing your sister and then seeing the vehicle that she was killed in every day. And they all agreed. And he was like, wow, I've never thought about it. So something like even that simple of asking them, like, so people don't think about certain things as being traumatic. But that for him was really helpful for him to go, oh my God, I was traumatized as a child. I never thought of myself like that. And then going into Vietnam as a door gunner, I asked him that question. And then he said, no, not until you just said that, but I guess I was traumatized. And then he says, realizing this connection helps me put into perspective this anger and rage I had towards my father. I carried with me the entire time I was in Vietnam. I knew that I couldn't stand being at the base when people were asked to volunteer to clean out the medevac helicopters, the blood inside those vehicles. So I ended up saying, no, I'd rather just fly. Just don't put me on that volunteer. I'm just going to fly more, which he said was more dangerous and crazy than actually staying where they at the base and doing this medevac cleaning. He said, I never put those experiences together, cleaning out my sister's blood with cleaning out the medevac helicopter. I can't believe I never thought of this until now. So here's an example of how these kind of parallel situations, he couldn't understand why when he was flying, he had this rage about his father. But there are times when he would say, it was weird. I would be in the air, we'd be doing our thing, and I would just be thinking about my dad and how angry I am. But what he probably didn't connect together at the time, definitely not, but even then, is that he might have actually been on that particular flight because there was this other option to clean out a medevac helicopter, and he didn't want to do it. But he did not make that connection. For this particular veteran, this connection for him, like, sort of was like mind-blowing for him. And to this day, even when I've seen him since, he has said that changed so much of how I thought about my time in Vietnam. So continuing this, his involvement with flying dangerous missions in Vietnam resulted in another traumatic event when his friend died in a helicopter crash, and Mr. B was denied the ability to retrieve the friend's body due to the area being too risky. So this is now going to be an overlap between military/trauma history disclosure and post-trauma or post-event. And Mr. B had never grieved his father's death, or his friend's death, even when given the opportunity to do so. And after lengthy discussion around the circumstances surrounding the death of his friend, the refusal of his commander to allow anybody to fly into that area where his friend was killed, because it was like they were sort of out of bounds, and the multitude of decisions and information which he was not told, the veteran was able to consider other contextual contributions to the situation. So what happened was he was really mad at this commander, said, I have never grieved my friend. I'm not going to grieve my friend because I was denied the ability to go get him after he was killed. And he said, I volunteered. And the commander said, no, I don't want to lose any more people. And we had to go through a series of questioning to get him to think about another way, think about the fact that his commander probably had extra information that the veteran was not privileged to hear, that likely made him decide, no, I'm not letting anybody else in that area. And it wasn't just the veteran, but the veteran, because he had not told the story before, never had a chance to hear this other perspective that helped him go, oh, yeah, okay, maybe that's right, which then allowed him to give himself permission to grieve his friend. But meanwhile, because he was stuck on this problematic thought about his supervisor, he didn't think I was good enough to get there and back. I was one of the best, right? And so he didn't want to lose another good pilot and door gunner. So by the time the groups were ending, the veteran had decided he would plan a trip to the Vietnam War Memorial in DC to grieve the loss of his friend. But that took a lot of providing this other contextual background for the veteran, because people get very siloed in their thinking when it comes to traumatic events. The body says they have to silo in, but the problem is every time somebody is re-triggered, they also sidle in and they only focus on this. So part of disclosing and sharing and the full life perspective allows that silo to open up, that focused thinking opens up, and it expands somebody's perspective of the event within the context of a lifespan, and sometimes actually helps people connect. So Mr. B, just to close this part out, he started with shaking. Remember, he came to the vet center because he shook. So while he was sharing about traumatic events in the war zone, the shaking would start again. And he would notice this. Other people would notice. It was pretty obvious. And around anniversary times, which he did not understand anniversaries, trauma anniversaries at the time, but during anniversary times, he's more likely to shake. But part of the reason why Mr. B ended up at the vet center when we went into his post-military disclosure was because he actually started shaking, and the trigger for the shaking was because he had talked to a work colleague a few weeks prior about the work colleague telling him, hey, Mr. B, I'm going to go to Vietnam. And Mr. B says, really? You're going to go to Vietnam? Well, where exactly in Vietnam are you going? And the colleague says the area that another traumatic event had occurred. In fact, it was this incident here about the friend dying. That particular area is where this colleague was going. And not soon after that, Mr. B started shaking. And he did not know that the shaking and the work colleagues' disclosure about going to Vietnam and then naming the area of Vietnam that he was going to go to ended up being a trigger for this physiological reaction of the hand shaking. He did not put that together until we got to the post-military part of his life story. So it's the ability to make these connections and helping the clients understand the full life perspective, and then putting those traumatic events within that context, and sometimes helping them. It helps them sort of bounce around and realize these connections actually at times helps dissipate the traumatic stress symptoms for them. It actually helps them go, oh, okay, now I understand why I'm reacting the way I'm reacting. And sometimes that explanation is helpful to help lower the reaction. It also helps maybe diffuse some of that negative self-talk that is often underlying some of these PTSD symptoms that people have. And so I really felt like this life review was beneficial. But now let's see, in terms of the numbers, how they played out. And so I'm
sorry.
Sure.
No, this is Ann Masters. I just wanted to let you know that there's a question. There's actually a couple of questions.
Great.
So I didn't know if this was a good spot to.
That's perfect.
Okay. So one of them is just for probably on everybody's mind. Do you want people to just take breaks as they need them, or were you planning a full?
We never talked about that. I was thinking about that too. I was like, well, I could just blow right through the 3 hours, but hopefully I can see that people are taking their own breaks.
Okay.
Let me think. Or I could take, will people come back?
Well, my experience is yes.
Okay.
that they are coming back. We could ask people if they'd like to take a group break, or
yeah, we could take a 10-minute break. Would that be good? Like 10 minutes? Does that sound okay?
That sounds great. And how about I ask you this other question first?
Okay.
You can answer that before the break. The question is about vicarious trauma and the experience of holding the trauma stories of others. And is that something you addressed?
I will not. I don't plan on addressing this here. I know that, so our groups knew that there was going to be disclosure, and they also knew that we were going to get into the weeds. we were really going to go in there, and that there would be a triggering element for everybody, right? And so it was really about reminding the group members every single time we had that kind of session, please, like maybe part of the closing checkout would be, what are you going to do to take care of yourself today? Knowing that we all did some degree of heavy duty work today. What are you going to do to self-care? That's not consistent with maintaining the PTSD. So it would be like, so I would remind people to stay grounded and do as much self-care, because that was also good practice. In terms of my own vicarious traumatization, I actually have it's really about balancing my life outside of my job. And that has been the number one thing. So I balance it so my job is sitting, listening, thinking, compassionately connecting, thinking, writing. So it's all of that in sitting, sitting in one room or another, walking down a hallway to another room, right? meeting. So at the time, of course, now we're sitting, all of us are sitting all the time. It's really about okay, so what do we do to counterbalance that? And so I play a sport that's pretty out there. It's very mindful. It's the music, it's movement, it's using non-words. I get out in nature, in the quiet. I minimize some of my conversations with people after I'm in big sessions or I've had a big day of therapy. So I just sort of do a little mini time out just to have the quiet and listen to music. My commute home was really helpful because it was a half-hour drive. You know, nobody was there, just me. And so it's really about balancing. And I think that also, I've always adopted my, my thinking. I mean, I'm not disaffected by people's stories, but oftentimes my thinking as I hear somebody's disclosure, no matter what it be, and as heavy duty and horrific as these stories are, I've always landed in, oh, I am so glad that they finally are doing something with this information. I'm so glad that they are reaching out for help in order to actually heal from this. This took so much courage for them to be here. So for some reason, that thinking and then my curiosity about where this stays stuck for them, and what is the unfinished business that their traumatic stress symptoms is trying to like tell them of sorts. I mean, I think it's the combination of my balanced life, my thinking about their courage, and my joy at them moving out of this stuck place, in addition to my curiosity, have all really helped me kind of keep that vicarious traumatization at bay. I'm not saying that I mean, I gotta say that I would not have been able to do this work for over 20 years at the intensity, as you probably are picking up on, at the intensity of which I've done it, without having those three things in place. So, so I've maintained a fairly good, I made sure I got my notes done before I left. So that way it felt like I had closed out the session, closed out the day, and was able to close that out, and it wasn't dangling and following me home. I did not talk about my work with people at home. So, so that's kind of how so the group, I would make sure that they would support each other. I would facilitate them sharing information from each other. But I never really ran into a situation where somebody got so overwhelmed. If they did, I would facilitate away from the protagonist and then bring somebody else in. But to be honest with you, somehow that did not happen during this process. They would get affected. They'd say in their feedback, yeah, I had something similar happen to me too. And I said, well, maybe that's something we need to talk about sometime in the future. Will you, let's remember to talk about this, because maybe this is something. Or I would say, okay, so as I'm talking to Joe over here, I want you to listen in, because I'm also going to be talking to you as we address this. But again, the uniqueness of people's trauma stories is such that there was an ability to kind of allow them to separate also. It wasn't the exact same. It was never the exact same story. They would talk about firefights, but they would talk about it so specifically that people were able to focus in on the unique aspects of someone's story. Okay, so that was a long answer to a short question.
Great, thank you.
All right, so it's 1:18. Well, it's 1:18 for me. It's
3:18.
Okay, so let's say 3:30.
Yeah, 3:30 sounds great, and everybody can still stay connected. Just, you know, turn your video off if you want to. And if Angelita is around, I need a second from you. If you could turn your, if you could unmute so I could ask you a couple of questions, that'd be great. Okay, so yeah, so I didn't see you on the registration, and that's okay. I just need to get some information from you. So what's your agency?
Oh, I'm actually I'm just here observing Lori. Dr. Daniels is my supervisor for MSW program. So I'm actually just sitting in. So is this for CE credit? I don't think I need.
Oh no, it's actually we've got we offer these trainings for our funded programs for veteran seniors and human services levy, and so So I just had your name out there. I'm like, I couldn't match it up with the registration, and I just wanted to make sure.
Okay, so I know, let me see, I think is it Tom? Yeah, Mr. Tom sent me the Zoom link and had Lori on that too. So I'm just
No
here. I
problem.
didn't register like probably like everyone else.
And that's okay. That's okay, because
Okay.
I understand your role. So that's, thank you so much.
Yes, ma'am. Thank you.
All right, you're welcome.
It is half past the hour now. Are
Yep.
folks back?
Yeah, I think you're good to go. Thank you.
Sure. Sorry, I didn't think about that. Usually when I'm presenting for you guys, we have that incorporated in, but because we're virtual, I completely forgot about this part. So
I'm not sure if you can see that question in chat.
will there be any discussion? Okay, one about the sport and the other about this. I'll do the substance abuse disorder and treating PTSD first. I will not be able to extensively discuss substance abuse, but I would say that a vast majority of the veterans that I work with do have a history of abusing substances, and that's supported by the literature that 80% Vietnam veterans actually met the criteria of substance use or substance dependence sometime in their history if they had PTSD. So, but I can tell you that in the context of talking about someone's life story, you do hear about them abusing substances. And so the connection between using alcohol or drugs as a form of detaching from emotions is well documented in the literature within PTSD. So it's not uncommon. In fact, one of my first publications was a chapter about treating PTSD or substance abuse within the context of PTSD treatment. And so it's not a secret that those two things kind of go together. And when you talk about someone's life story, you do hear about how substances have been part of someone's life as either coping mechanism or something that they were predisposed by their upbringing or by parental role models or adult role models when they were children. So that kind of thing happens. And so again, kind of staying extremely client-centered in all of this. That's part of what this whole process is about, is really honing in on a client's unique traumatic stress and unique trauma story, which may include the use of substances. And substances sometimes are part of how the trauma occurred too. In sex assault, it's actually pretty frequent. You'll hear about somebody being intoxicated or in somehow disempowered as a result of abusing substances or somebody drugging them in some way. So so substance abuse would be a part of the story that's being told. And obviously then an intervention for sobriety support or abstinence support, you would want to integrate that in there to help them also understand, if they understand how it's operating within their traumatic stress manifestation, right? If PTSD is stuck, but substances is part of their coping, then obviously you could then intervene at that level and logically argue that if they really do want to change the quality of their lives, they need to reconsider that. It actually, throughout the group, I would ask that clients would, if they were still actively using, I would ask for them to contract with me that they would not abuse substances prior to 24 hours prior to coming into group and 24 hours prior or after leaving the group. So they would have, I would have them create like a window of abstinence or sobriety. Now, I'm not talking about prescribed medications. I'm only talking about things that were being abused. And so with my clients, even in all of my groups, I actually ask them, look, you're making this investment in you, and we are all part of this investment in you. So part of the contract I'd like you to consider, because I wasn't going to monitor them. I didn't have the resources or the time or the energy to monitor them. It was like I would say, this is for you. And if you want to maximize your time in these sessions, I would like it if you could consider not drinking for 24 hours prior, or not abusing substances 24 hours prior to you walking into this office, and not using or drinking 24 hours after you leave. And this way you create this pocket of processing. Because when people talk about their traumatic events or they're learning something new about themselves, like these connections that Mr. B made that I shared with you guys, and this happened several times with clients, what would happen is that their bodies are still processing. So somebody leaves your office after having done some work, and they immediately go back to this substance abusing behavior, then they sabotage the work that's been done. Their body doesn't get a chance to kind of integrate and process the aftermath, because clearly clients are processing well after they leave our offices. So I had them contract with me this pocket. Just create this pocket. I'm not asking you to you don't have to go to AA meetings, although I'd encourage you to go to AA meetings or NA meetings. I said, I want to create this recovery pocket for you. So then that way, at least you'll get some momentum from this. And most people adhered to that. And if they didn't, they would share during group, oh, well, I ended up doing this last night. I was like, okay, but they're the ones that end up with the consequences of that. So it was really kind of just having them commit to their recovery process, not just by showing up to group or showing up to individual sessions with me, but to really like say, we're going to work on this together. We're in on this together. So part of your, besides driving all the way over here and sitting with me for an hour and a half every week or every month or whenever it was, I want you, let's create this. So then that way the work that you get done in our sessions doesn't get in any way compromised. And so that's how I would treat substance abuse. But it was very, very specific to that person's abuse of substances and how it was impacting on their recovery commitment. The sport that I'm involved in is a very high level of Frisbee, believe it or not. I'm an ultimate player. I play disc golf and I'm a freestyler. And I've been doing that since before I was in college, and I never gave that up. And I will say that is when you cannot, it's very mindful. I figured this out years ago. It's very mindful because when I focus on a flying disc, either throwing it or receiving it, in some way, there is no past, there is no future, there is only currently now. And literally it is mindful because time just disappears. And so freestyle specifically is movement with a moving disc, and I have control of a moving disc, and I move around that disc, and it's to music, and it's with partners, and it's outdoors, and we're using the wind and the elements and all sorts of things. And it's almost anaerobic activity, and I've been doing that for almost 40 years. And that has been actually probably a key part of my ability to sustain in this intensive traumatic stress work that I've been involved in. And it occurred to me a long time ago that those two things balance each other out pretty nicely. I mean, if I used to leave work and then go straight into a situation where I was playing Frisbee with my friends, like at a park after work or something, and in Oregon, because it's just like Washington in the summertime, right? It stays so late, you could do that. Sometimes it would take me about half an hour to kind of slough off the work stuff and then get into it. But that's exactly what would happen, is that after a while, all the work stuff would sort of disappear, and then I was focused on what I was doing now. And when people are throwing Frisbees at you at high speed and high revolution, then you sort of have to pull it together pretty fast, or else you're going to get hurt. So anyway, so that's the sport I'm involved in. It's a very niche sport within a niche sport. Okay, so any other questions before I return to this? Okay. Just feel free to interrupt me if that be the case. We're going to go into did this work, or how did this work? And then I know that I think we're finished in about 20 minutes. So I'll try to leave a few minutes for that. So just so really quickly, I handpicked what I'm going to share with you, only because I think that most people probably are interested in depression and PTSD and then the reminiscing stuff. But I will say that overall, I was very happy with the outcome of the group I did. And I really learned a lot in this process. And I feel like the veterans that I worked with learned a lot about their lives and learned a lot about themselves and their own PTSD. But specifically around depression, I use this special measure called the Older Adult Health and Mood Questionnaire, which I said briefly before, aligns really well with the DSM criteria, at least at the time, the DSM 4TR criteria for depression. And it looks at no depression, depressive symptoms, and then it also looks at major depression. So specifically, I'll just show this to you. There's this, I don't know if you could see this, but there's this green line here, and then there's this other green line below, okay? Sorry, that second green line is not fat or, you know, thick enough. But anyway, as you can see, this is the code for the depression measure, and it says if somebody has 0 to 3, they have no depression. If they're at 4 to 10, they have depressive episode, and 11 to 22, they have major depression. So both groups together, at the very beginning of groups, right here, the mean group score, pre-group, for both groups together, fell within the major depressive category. So they all had major depression, according to this measure, before starting the group. And then 3 months later, approximately, was the first time that we did a measure that was after the group started. And then you can see a slight increase as the crossover occurred. And if you remember, I told you that one of the groups got a little nervous before they switched to the autobiography. And this is kind of showing a bit of that. And then it decreased. And then by the time the groups ended, which is that gold star there where it says groups ending, that's back in March. And that's when we actually stopped the groups. And then I gave Jim gave them those post questionnaire information. And so what happens there is you can see that there's a slight decrease in depression. And then, oops, didn't mean to go that far. And then 3 months afterwards. So as you can see, they toggled down from major depression and then kind of fell into the category of depressive episode, but never really got out of depressive episode. So this was like, oh, it's a little like, oh, kind of disappointing, but not entirely. But then it was suggested to me that I split the group information. And in doing so, I ended up color coding the groups into the blue line represents the group that got the life review / autobiography first in the first 3 months, and then got the regular here and now group afterwards. And the green group, actually, the green line is indicative of the here and now group. Again, showing the same legend up here in that box. Everybody started with major depression, but one of the groups, the life review group, actually dropped into the depressive episode category pretty fast. And then, as you can see, they stayed there. And then near the very end, as groups ended, they started venturing into the no depression category. And then 3 months later, that was maintained. This finding was so surprising to me with this group. They're the morning group, by the way, that I actually went into the raw data because at that point I could and double checked to make sure that people actually were answering it correctly and it didn't get input in the computer wrong. And sure enough, several of the life review to regular PTSD here and now group actually did report not feeling depressed. Whereas on the green line, you can see that that group who got PTSD first and then the life review afterwards never really left the major depressive area. And in fact, after groups ended, their depression went up a little bit. And so it was interesting because it was as if what changed? It wasn't really clear what changed, but in terms of the effect of the group sequencing, the group that got life review first and then regular here and now therapy had a very large effect. And actually, in terms of clinical language, this would argue for the sequencing of being, yes, let somebody tell their entire life story first, and then you can get into the here and now stuff, because now the here and now stuff has a larger context, which is the person's life story that you are now aware of. In regards to PTSD, I used two different measures, one of which I'm going to share with you now, which is the PTSD clinical list, which is the military version. The updated version of that is now the PCL-5, but at the time I wanted to use the military focused one. And again, showing you just the data from the consolidated groups. This is again showing how the groups actually, there's a yellow line there. That yellow line, yellow horizontal line, is showing me that, or showing all of us that this is the cutoff for PTSD. And as you can see, 54 was where they all started. And so both groups had clinically significant PTSD. Then there was a slight decline and then a slight boost at the crossover. This is the crossover number 3. And then it declined a little bit more and then just skirted the edge of the measures cutoff for PTSD. And again, so again, the effect was moderate. But when I split the groups, again, the blue line being the life review to the PTSD, the green line being regular PTSD, here and now therapy to life review, the same sort of finding with the depression came out with this one too, which was the sequencing seemed to connect people together with the life review early on, and that actually helped contribute, although they were still at the crossover within the PTSD criteria. By the time we finished the groups, they were below the particular cutoff for clinical PTSD. And so therefore, again, the sequencing for the blue line group was that there was a large effect size and statistically significant. But also, as you can see in the bottom of this slide, there's clinical significance, which means that the degrees in the authors of the PCLM said, if you see a reduction of 10 points from a person's pre to post on this PTSD measure, and this holds through for the PCL-5, by the way, then that means there's clinical significance. So whether it's statistically significant or not, because with a small sample size like I have, it's the statistical significance, it's unlikely it's going to happen because the sample size is so small. But regardless, even with this small sample size, the drop clinically is significant. In other words, that group actually did state in their questionnaires, and they didn't know because there's 3-month gaps, that there was a significant reduction in their PTSD to a point where they had some symptoms, but they were not within the cutoff. Meanwhile, the green group, again, had an increase at the crossover and then a slight reduction, but they never really got out of the criteria for that. And then when it came to, did they reminisce differently? So this is one of the areas where I ran what's called a correlation, which means I'm looking at if the increase of one adds to an increase of another. Using the reminiscence function scale, I wanted to know if bitterness revival reminiscence actually changed to more productive reminiscence. And I actually correlated this also with the 2 PTSD scales, the PCLM, which I just shared with you about, but also what's called the late onset stress symptomology PTSD measure, which is really set up for older people with PTSD, by the way. And it looks at later stage of life PTSD, taking into account the fact that people's life circumstances change, therefore their PTSD might change over time. And so what I found was that there was no significance between the PCLM and bitterness revival subscale of the reminiscence function scale. Reminiscence function scale has 5 or 6 different kinds of reminiscing styles. There's subscales, so I only looked at the bitterness revival questions within that scale, found nothing significant there. Also, when I looked at geriatric morale, I didn't see any significant changes between the revival and morale. So in other words, there was no change really between PTSD and morale. I also, though, did see that with PTSD, there was almost a statistically significant change between the problem-solving type of reminiscing kind of increasing and a reduction of PTSD. So there was kind of a medium size reversal, which means the lower the PTSD symptoms reported, the higher the problem-solving reminiscing occurred. So that's a kind of sort of okay finding. In regards to morale, there was also a statistically significant difference. In other words, as PTSD went down, morale went up. And then in terms of was there actually an inverse or reverse correlation between bitterness, revival, and problem solving? That was kind of weird because it meant that higher bitterness, revival, higher problem solving, again, almost statistically significant, kind of a weird finding there. And so really what I decided was this reminiscence function scale wasn't really capturing reminiscence the same way that veterans were reminiscing, although there was a couple things that were kind of interest. It was not exactly what I had. I was expecting something probably a little more drastic than what we found. But I did ask this qualitative question, and this came from the literature actually, from one of the authors who I actually met, and she asked me to look up this article, and lo and behold, this forgiveness question became the only qualitative question or non-quantitative question that I asked. And I asked that every single time, all throughout the measurement periods, which was, do you forgive yourself? And then I had them handwrite their answers. And so here's a comparison of, and I've lined these up with a majority, I couldn't fit them all on here, a majority of these. But if you look in the fall of 2012 during pre-group, you can see what people wrote there. And then across the way at December of 2013, this is what they wrote near the very end. And so I'm just going to pause here and I'll just shoot these arrows across so you can see how people switched in terms of their thinking, in terms of forgiveness. I hope I didn't cut anybody off on that, but hopefully you got a sense that it seems as if there was a shift in terms of forgiveness, that over time, at least 6 of the veterans, and there's a few more in there, they really did shift in terms of their thinking and their forgiveness of themselves. And that was as a result of being in the groups in general. So my conclusions are that sequencing of the group conditions may have made a difference. So having veterans share their life story prior to less structured PTSD group therapy, or any therapy for that, may have helped them bond more quickly with each other and maybe prime them better towards working on their war experiences in the latter 6 months of the study. Life review may have a functional role for older war veterans in a group setting in terms of bonding, connection, not feeling alone, and shared histories. In addition to that, the reminiscence function scale was not really a true measure of how memories of war are experienced. And so intrusive memories that are indicative of PTSD may not actually be considered by the veterans that I had in this study the same way as reminiscing type of memories. And adding, because intrusive memories are unwelcome and unelicited, whereas reminiscing, sometimes those get elicited. So memories may be falling into different categories for veterans. But adding a life review component after a group has already begun working on here and now PTSD may not actually change veterans in terms of their symptoms. It's really the anticipation of sharing in a structured group format brought up some of the symptoms as we saw during the crossover. And when I consolidated the groups, by the way, after the study was over, the people from that green line group, the group that didn't really actually change in terms of PTSD and depression, actually seemed to shift into this other healthier mode after a while. And one of the vets actually said to me several months later, you know, if you did your assessments on me, or if you did those scales on me now, I would probably be different. And so there was, because now we were in here and now, and it was the same sequencing as them just finishing the life review. And then the consolidated group was the here and now for them after life review. So again, it seemed like people moved better in terms of how they approach their symptoms and their disclosure of the symptoms and their treatment and recovery. They sort of had a different approach towards all of this, and they seem to respond better to therapy. And of course, just like any research study, there's all these limitations. I had a very small N size, and it only takes 1 to 2 people to actually influence the outcome of an entire group of 6. I also had attrition, which I told you about, which is inevitable, and it's part of doing a study like this. And so actually much of the findings that you saw were based upon the remaining 9 people in groups. The study site actually was a vet center that's in an urban setting. So this only speaks to that particular vet center in that area. And it was not a highly diverse area because although Portland, Oregon is diverse in some ways, it's not as diverse as you could see in my sample. And then one group actually had higher levels of morale and satisfaction with life at the onset of group meetings. And of course, I did not know that until after groups had started and ended. So when I actually split in terms of life satisfaction and morale, ironically enough, the one group that did respond better, when I split those scores on, they actually had presented with already like a higher level of morale and life satisfaction. But of course, because I randomly assigned them to one of 2 group conditions, I had no idea that there would be this potential. So this could actually also influence the outcome, although I couldn't control for that. And social support was not measured, which in a subsequent study, I would totally do that again. My PhD was based on PTSD and social support among Vietnam vets. So it was ironic that I didn't add a social support questionnaire in there. I felt like I was greedy already, but I ended up not adding this. And I think that had I done that, I would have seen that social support would have changed over time, since it was clear that both groups ended up connecting together socially near the end. But overall, I'd say long-term psychotherapy really does help aging trauma survivors over the course of several months versus short-term shots of therapy. All but 3 clients reported improvements, and of those 3, 1 was the same, 2 had slightly gotten worse, but not at a clinically problematic level. And then also talking about traumatic events that happen once therapy started did not result in symptomatic regression by the survivors. They actually did not fall into what's feared by many practitioners as like going into like full-blown relapse. And so for whatever reason, the structure of the group was enough to keep, I mean, some triggering and some recharging of PTSD will happen when you talk about traumatic events. And in spite of that, it was still manageable for people. And they didn't go, like, we didn't have people acutely hospitalized as a result of listening to these sessions. So it was manageable. And I also warn people that they have to take care of themselves. And yes, this is part of it. It's to be expected. It's not unusual. So Community-based counseling can be effective venues, and client-centered, insight-oriented trauma processing can work for people in terms of reducing their PTSD and depression symptoms, increase social support, improve their overall functioning. So there's a picture of me back when I had darker hair, and then also the crew. So Jim's there with the badge on. He was the co-PI, and then here are several of the veterans. This is actually the first time that they ever met each other. It was after groups had ended, but for a social engagement. So anyway, thank you so much for your time. If you want to read more about this, I'm talking about, this is my argument of gerontology and PTSD folks need to get together. We need to help people actually reminisce. That's the bottom line. Let's facilitate people, older, aging, trauma survivors. Let's have them tell their story, because my story that I'm telling you here is a reflection of their stories. And I really, I hope it had a multi-layered impact. And if you guys want to learn more and geek out a little bit more about this, I was able to get 2 peer-reviewed research publications out of this. They were published in 2015, as well as a chapter in this book called Social Work and Aging, where I talk about reminiscence and life review only, but the specifics, if you want the grueling details of this study, are published in these 2 publications. And that ends my time with you now. Any questions?
We do have time for questions on this end, because I think I told everybody it would end at 4:30, so we do have.
Oh, 4:30. Oh, okay.
If yeah, so if you all have questions, please unmute and ask them.
Horacio here from Plateau Outreach. Just a question. You talked about PTSD from sexual abuse. What's the correlation between that and the military PTSD, or is there any?
Okay, that's a great question. And I actually had to make that transition myself, because so much of my career had been focused on war veterans and the situations that occur in the war zones. And then when I went to the vet center, my role was different. So I felt comfortable treating PTSD with war veterans, but less comfortable working in regards to interpersonal violence and sex assault and rape. I had not really, I've had a few clients that I had worked with along the way, but now that was my entire client group. And so I'll tell you now that there was a lot of overlap. There's a lot of overlap, but working with the sex assault survivors really helped me solidify my thinking about traumatic stress being unique to each individual, and the uniqueness of the trauma story and how that relates to their PTSD symptoms. So it's really, so I had a sizable caseload, probably, if not the highest caseload, which I didn't know about for a long time. I thought every military sexual trauma counselor in the West Coast had 40-something people, but that was not the case, apparently. And so but I had to develop something, right? Because this is another thing that is under, and I'm writing a book about this, so just to let you know, hopefully this will be something that is not so sparse in terms of tools. But in 2008, when I started working with MST, I actually ended up not finding a whole lot out there that was specific to MST that I felt like was client-centered enough. So when I started it, so before the evidence-based practices started, so I started working with trauma survivors in the late 1980s, early 1990s. So yes, I'm not young, but I started when I was like pretty young. And so what happened was we did only client-centered work. We didn't have all the, prolonged exposure and cognitive processing. We didn't have it all kind of, it was there, but it wasn't there the same way. Prolonged exposure was known as, immersive therapy, or, I can't remember what they used to call it, but then CPT was around, but not in the same, it wasn't packaged the same way. So when I was working with MST survivors, I relied kind of on my practice or how I understood how to treat and talk about PTSD with war trauma survivors. And there was so much overlap. The difference was what traumatized somebody and the lack of social support afterwards. So with sex assault, depending on the situation, but the clients I worked with would not only be assaulted, but then there was this other layer of institutional betrayal that got coupled in with that, because people who said initially, we'll take care of you, you're part of us, we're part of a larger team, you know, we're a unit, we function together. If they got assaulted by somebody within that family, it was very much like incest. And then if they reported it, then they ended up in this situation where the system would turn their back on them. And so then they were further isolated. And so the parallels between that and being in a war zone, like the war zone, everybody knows about the traumatic event, right? At least in the close circle. People are aware that somebody got killed, for example, or that there was a firefight over here, or there was an RPG went off over there, right? So people, there is at least some semi-public knowledge of that incident occurring. So therefore, there's some flexibility in thinking and tolerance if somebody's having a response to that, an acute response to that. Whereas somebody who's sexually assaulted, that's why they call it the invisible war, right? That's why that documentary exists, called The Invisible War, because it's not as visible. And once it becomes visible, the trauma survivor then faces retaliation or rejection from their supposedly existing peer group. And if that doesn't happen, then they shut down even more. And then there's the issue of, was the person who was assaulted a female or a male? Because then there's all additional dimensions that happen with male survivors of sex assault versus female survivors. It's not saying it's worse or better, it's just different. And so there's but when you get down to actually the symptoms, triggers exist, intrusive recollections exist, traumatically based nightmares exist, feelings of reliving exist, the physiological hyperarousal exists, the distorted beliefs of choices that somebody made, those also exist, those secret thoughts and self-denigrating thoughts, and then the avoidance and detachment also exist. So all of the symptoms match. It's just a matter of determining specifically who, like for your situation, trauma survivor, what do these look like for each of you, for each of them? Because I didn't even realize that one of the clients that I work with, who's a male sex assault survivor in Portland, he never understood why, and I talk about this in one of my other presentations, he never understood why every time he went into the lumber area of Home Depot, he would get a panic attack. It seemed like such a weird, random thing for him. But when he was in therapy and we really talked about what happened to him, it was through that conversation that he realized that while he was being assaulted, he was actually facing a piece of wood. And so because of that, and it was only because we knew his story, because he disclosed his story, he was brave enough to disclose his story, he was able to figure out a trigger that would have otherwise been lost on him. He had no idea. And then it just made so much sense. And so once he started understanding his triggers and realizing how often he was getting triggered and that the triggers were directly related to this incident, then he was able to actually forgive himself for having these anxiety attacks. He was less self-abusive. He was he was more tolerant of himself for having this, and he was less self-critical of himself. So it's really and so this, I really argue for a person-centered, client-centered approach, because especially around traumatic stress, because it's easy for us to try to silo people into these interventions, and these interventions do fit for certain people, but they don't fit for everybody. So I used to pick and choose who would get, you know, once I was trained in CPT, which was very, very late in my career, I'd be like, well, maybe this, you know, let's try the CPT on you. But I certainly didn't offer it as a blanket intervention for every one of my clients, because not every one of my clients is going to want to do the homework and walk around with the forms and fill out the stuff and go through the manual. Most of my clients just wanted to talk story, as we say here in Hawaii. They just wanted to just talk about it and have somebody listen and think through things and help them get unstuck. And that doesn't always fall into the lockstep procedures that some of these evidence-based practices have. And then I used to inherit people from prolonged exposure. People would just like, so I got the people who are evacuating the VA and coming into my office because they like heard about prolonged exposure and what it entailed. And they were like, I don't want to do that. I'm not ready for that. I'm too new, right? It's scary enough to come into therapy. So I inherited several people from prolonged exposure. So I guess my point being, there's a lot of overlap, and in your assessment of traumatic stress symptoms, that's where you learn about the specific version of a client's or their PTSD.
Thank you.
Yep. Oh, thank you, Tom, for putting the references up. Appreciate that.
Do we have any other questions for Dr. Daniels?
Yeah, and I usually don't actually, sorry to interrupt, and I don't usually send my slides out specifically because I just put the content of the slides in that Word document, that handout, because a lot of those slides are just to guide me through the presentation and make it more interesting. But the context that I think is most relevant to you guys are in the Word handout that I think I sent Tom and he should have sent out to you.